Hello, and welcome to this webinar. This is the first of the Mental Health Spotlight webinars, which are part of the Lancet's 200th anniversary celebrations. The focus of today's gathering is the law as it relates to mental illness, and in particular the laws relating to suicide, specifically criminalisation and decriminalisation. The agenda, briefly, is a pre-recorded video outlining the current global situation from Natalie Drew from the WHO, followed by a live session of two pre-prepared questions that I will put to our four esteemed panelists. That's Murad Khan in Pakistan, Helena Wang in China, Frank Anthony in Guyana, and Ahmed Baraneh in Jordan. This will be followed by an open questions and answered session, and I will formally introduce our speakers later after the pre-recorded video. But before that, I would just like to give a little context about what we want to talk about here. Ending your life by suicide, or attempting to end your life by suicide, has concerned all cultures since ancient times. Most, although not all, have regarded the act as wrong, either as an act against the prevailing religion or traditions. The eminent philosopher of the Middle Ages, Thomas Aquinas, condemned suicide on the ground that it is a violation of God's domain over human beings as their creator. Contemporary religious viewpoints, including Buddhism, Hinduism, and Islam, remain opposed to suicide and attempted suicide. And from these religious foundations, most countries have developed their laws, and consequently, suicide and attempted suicide became, in many places, illegal or criminal acts. The issue has been repeatedly revisited and re-examined in countries at various times as public opinion, coupled with scientific, medical, and legal developments, has changed. And it may seem obvious that to punish someone attempting to end their life by suicide, or to subject the family of someone who has ended their life by suicide to some form of legislative retribution, is humane and uncaring. However, before such an opinion can be reached, it must be accepted that suicide and attempted suicide are not just moral matters, but are medical ones, and that suicide and attempted suicide are evidence of mental illness which requires treatment and not punishment. A brief review of the times at which a handful of countries have come to such a realization, subsequently decriminalized suicide and attempted suicide, illustrates how difficult it really is for such changes to come about. For example, Denmark decriminalized suicide in 1868, Finland in 1910, Hong Kong in 1967, England and Wales in 1961, and Ireland in 1993. And as we will hear from our guests, the thing is still in a state of flux. Finally, it's just necessary to appreciate that even though laws change, the behaviours of doctors and law enforcers and others responsible for using them may remain entrenched and unmoved and prejudiced. The opposite, i.e. the adoption of more understanding and caring attitudes towards people who have attempted suicide and the families of people who have ended their lives by suicide, may also be seen, meaning that although the law may not have changed, behaviours, treatments and attitudes have. It is both these rather difficult situations that contribute to the major problem in this area, and that is proving statistically beyond any doubt that decriminalisation of suicide and attempted suicide does not act as a deterrent, and that by doing away with the laws, lives will be saved. But before we move on to this pre-recorded video, I'd just like to give a little bit of information about the electronic platform that we're using. And that's firstly that attendees can submit questions during the webinar, if they wish, using the Ask a Question box on the dashboard there. Further information about our other spotlights on mental health content can be accessed through the box related Lancet 200 resources. And also the boxes that appear on the webinar dashboard can be adjusted and minimalized. Finally, on-demand version of the webinar will be available to one and all once we have finished here. And with that, I will now play the pre-recorded video from Natalie Drew, who sadly couldn't be with us, who is the Technical Officer for Policy, Law and Human Rights team in the Department of Mental Health and Substance Abuse at the WHO.
Colleagues, ladies and gentlemen, I'm very pleased to have the opportunity to outline the work that the World Health Organization is doing around the issue of decriminalising suicide. We know that globally suicide is a major cause of mortality and that it's the fourth leading cause of death among young people worldwide. Urgent action is needed, which is why governments endorsed the global target of reducing the global suicide mortality rate by a third by 2030, not only as part of WHO's Global Mental Health Action Plan, but also as part of the United Nations Sustainable Development Goals. However, a significant barrier to meeting this target still remains, and that's, of course, the fact that suicide continues to be criminalized in many countries across the world. And we know that the consequences of criminalization can be devastating, not only deterring people from accessing potentially life-saving care and support, but also exacerbating people's exclusion, their marginalization, pushing them further into despair, distress, and even poverty. So in order to shine a spotlight on this issue, WHO is developing a policy brief specifically on the decriminalisation of suicide. And the brief sets out the background for why decriminalisation is so important. So, for example, it highlights that despite the fact that 1 in every 100 deaths globally is by suicide, still today more than 20 countries continue to criminalise suicide, which is a major impediment, obviously, to suicide prevention. The brief outlines the devastating impact that criminalization has on people and, in fact, on entire communities. For example, people fail to seek care and support, putting them at higher risk of suicide. Families who've lost loved ones also fail to seek care and support for their bereavement. And not only that, but criminalization prevents the collection of accurate data on suicide, which in turn prevents governments from being able to develop effective suicide prevention strategies. Through case study examples, the policy brief also highlights how Singapore, Pakistan, and Guyana have recently managed to successfully decriminalize suicide through concerted actions including alliance building, targeted advocacy, public awareness raising campaigns, the strategic use of traditional and social media, and also the recruitment of influential political figures, among other actions. Finally, the brief outlines key recommendations that can be taken by countries towards decriminalisation, including repealing laws and policies that criminalise suicide, engaging with stakeholders to understand and dispel the justifications for criminalisation, and the training of first responders in effective and non-coercive responses to persons at risks. And then other recommendations include developing comprehensive national suicide prevention strategies, establishing rights-oriented, community-based mental health services, and of course also formulating new mental health laws that promote rights and quality care. So the draft policy has already undergone review during 2 expert meetings that we held in December 2022. The next phase is to undertake a major international review of the brief in the next couple of months, with a view to its finalization and launch later in the year. So through this policy brief, basically WHO is adding its voice to those of the Lancet Commission on ending stigma and discrimination, United for Global Mental Health, as well as the International Association for Suicide Prevention, and many others in calling for an end to criminalization. And through this brief, our aim is ultimately to engage countries in a dialogue around this critical issue and to provide inspiration and guidance to them in their efforts to decriminalize suicide once and for all. Thank you very much.
Okay, so we look forward to the report coming out later in the year. But at this point now, I just want to introduce formally with a couple of lines each, because I know my colleagues don't want to spend too much time with their achievements. I just will introduce them as we go through when I pass the questions to them. The first is Murad Khan, who's the Professor of Brain and Mind Institute at the Aga Khan University in Karachi in Pakistan. He's the lead coordinator for Partnership for Life and International Association of Suicide Prevention Initiative. His interests include epidemiology, socio-cultural and religious factors in suicide and self-harm in the Muslim world. Helena Wang is a friend and colleague who is our Asia executive editor of the Lancet, based in the Beijing office. She's a medical doctor, and she has been the lead on several groundbreaking projects of the journal, including the Lancet China themed issue. She has a particular interest in mental and brain health. Frank Anthony is the Minister of Health in Guyana. He is a qualified doctor and has taught at the University of Guyana as an adjunct professor in public health. He's been a consultant for several organizations in this area. He currently serves as a member of the executive board of the WHO, as well as other key programs and boards. And last but not least, Ahmed Bawanet is the director of programs and deputy country representative of the International Medical Corps Jordan office. And he has over 15 years of experience working in the field of mental health, particularly in the domain of refugees and other vulnerable populations. He received his clinical training in mental health in the US and has worked in several different international agencies, including the UN. So now I have the honor of putting to each of our panelists a couple of questions. For each question, I will reiterate, you've got 3.5 minutes, so please be succinct and as brief as possible. And I will try politely to interrupt you just as we approach the 3.5 minutes time. The first question is, and we'll start with Murad and work through Helena, Frank, and then Ahmad. The first question is, what is the situation in your country regarding the laws around suicide and attempted suicide? And leading into that, have they changed? If so, when? And how did the change come about? And so I will now pass over to Murad.
Thank you, Jonathan, and thank you for inviting me to this webinar. But I have some good news. As some of you may know, suicide was criminalized in Pakistan throughout the ages. Pakistan gained independence in 1947 when the division of India took place. But the law goes well beyond that to the 1860s, a legacy of the British colonial rule. After a long and a protracted strategy and advocacy, suicide and attempted suicide was finally decriminalized in December of last year. So that is a good news. It took a very long time to do so. So as of now, it's decriminalized. However, the process of registration of suicides and particularly attempted suicide continues as before. So while we have overcome one major hurdle, the work really starts to then educate the law enforcement agencies, the medical legal officers, the emergency medical room officers, the magistrates, the courts, the judges, and the police to then implement this law and for attempted suicide cases and suicide cases to be treated differently. So that's where we stand currently. Thanks.
You've just got a couple of minutes left. Can I ask, how did the law come about? What particularly then, was the mechanism for changing the law so recently?
So obviously this was something we were all well aware of. However, because of mental health and suicide was very low down on the importance of the food chain, no one paid much attention to that. But in the early 2000s, Pakistan's Mental Health Act was revised, And within that, people did express some concerns about the criminalization of suicide. So they introduced something called something that gave a certain amount of protection that anyone who makes an attempt must be examined by a psychiatrist, and if found to be suffering from any kind of mental disorder, must then be treated, and therefore the case should not be registered. So it was partial protection. Now, building on that, a few years ago, some people took up the cause. In particular, I must mention Taskeen, which is a mental health non-government organization that took it up, and then they started a campaign of public education, of advocacy, and gradually a change took place. And we were very, very lucky that a senator of Pakistan, Senator Shahadat Awan, took up the cause, introduced the bill. The first time, unfortunately, the assemblies broke up, but it was reintroduced and was passed through the upper house, was introduced to the upper house, the Senate, passed by the lower house, and finally it became the law after the president signed it. So it was a long process, and the advocacy and public awareness was, I think, critical in doing so.
Okay, fantastic. So let's move from Pakistan, a few thousand miles east, to China. And Helena, are you able to say what the situation is in your country regarding laws around suicide and attempted suicide? Have they changed? If so, when? And how did that change come about?
Thank you so much for your question, Jonathan. I don't think we have laws against the suicide in China. We don't have kind of laws, but we did have the China mental health law issued in the past few years. What I want to say is that I want to share some interesting findings from China's suicide rate, which is some interesting findings. For example, in the early 1990s, suicide was a serious public health problem in China, and China has one of the highest suicide rates among the world. But after that, suicide rates in China at both national and regional levels has substantially reduced, which are not because of any laws, but associated with economic prosperity and social changes. Actually, by 2011, China had one of the lowest suicide rates in the world. So, as I said, we don't have any laws against suicide, nothing related to any laws, but a rapid economic growth and social changes, which I think is amazing. That's the situation in my country.
Yeah.
Very happy.
Fantastic
information.
Well, no, fantastic. We'll come back to your thoughts about or the attitudes towards suicide and attempted suicide later on when we come to the stigma question, but that's very good. So there is no law in China. Let's move then to Frank Anthony. If you could let us know what the situation is in Ghana. Has the law changed? If so, when? And how did the change come about?
So thank you very much, Jonathan. In Guyana, we had a law that dates back to the 1930s. It's part of our British colonial legacy. And although we got independence in 1966, and the UK decriminalized suicide in 1961, this still remained in our books. This was something that people were calling for because we recognized the importance of decriminalizing suicide. But it's only last year that we were able to get a new piece of legislation drafted, and we took that to Parliament, and we were able to successfully pass that in November last year. So right now we have a specific piece of legislation that talks about prevention of suicide. And in that legislation, apart from decriminalizing attempted suicide, we've also been able to, by law, set up a commission, a multi-stakeholder commission to look at suicide prevention in Guyana.
When we spoke earlier, you told me that and again, very similar thoughts to what Murad has said, that it was that there were other more important issues pressing in your ministry before, but we also said, did we not, that it's now come to the fore. So again, it's sort of working through the most important, and then on to lesser important issues. And you said that was one thing that led to the focus on decriminalisation of suicide.
Yes, I mean, we have a number of things that were going on at the same time, and you can imagine also we were dealing with the COVID-19 pandemic. So all these were pressing matters, but despite that, we decided that this is an area that we have to focus on, and certainly we paid a lot of attention to this. Not only did we drafted this suicide prevention law, but we also updated our current mental health law, which dates back to 1934. So that too was updated. And in that, we were able to have a rights-based approach to mental health illnesses. So we have put that in the legislation, all the rights of persons who are affected by mental health illnesses.
Yes, perfect. So let's move to Ahmad in Jordan. Again, my similar question is then, what is the situation in your country regarding the laws around suicide and attempted suicide? Have they changed? If so, when? And how did the change come about? Ahmad.
Yeah, thank you, Jonathan. I think in Jordan, we did not have any law until 2022, 1 year ago, around the suicide or criminalizing suicide attempts. But last year, exactly 1 year ago, in April 2022, the government suggested a new law for the House of the Representatives. And the representatives approved the draft law to criminalize any attempt of suicide in public. That was something came as a surprise, because we never heard of any of those discussions around this. And the justification came from the government that it's that we're observing a lot of increase in the number of the death by suicide in Jordan. And of course, without going in details about what is the new law and what's the penal that the suicide attempt people they will be subject to, it's worth to mention that in the last few years, the number of the attempt suicide have increased, starting from, let's say, 2021, that was 169 cases. And those are the cases that they were reported as they completed their suicide. And we know that there are maybe few more of those that they attempted suicide, but it didn't work. It's worth also to mention that the WHO estimated that there are more than 1/5 of the Jordanian population that they suffer from the mental health illness. And we know that the mental health and the psychosocial support in the country are not perfect, evidenced by that there is only one psychiatrist for every 100,000 people. Speaking about psychiatrists, also mentioning the psychologists, that we know that we have even less per 100,000 for psychologists. So the overall situation is not great, but also this new law came made it worse, in my opinion.
Yeah, so that really is, completely different from what we essentially are, discussing and what the WHO is proposing. You've introduced a law where you didn't have a law making the act of suicide, and I know it's specific in public, is it not? Specifically in public, it's against the law to end your life or take your life by suicide. So it really is an anathema situation. But we could sort of say, just put it in a bit more context. And I have spoken to the Ministry of Health representative from Jordan, and he said it must be seen in context. Are you able to just put it in the context specifically around employment and youth and the economic situation?
Well, that's true, Jonathan. I think the overall situation, financially, politically, is not great, and also those lead to more challenges related to mental health, and I think that the increase of those mental health problems are coming with the roots of there is increase of the demand for on the mental health services came as a result of financial situation and also social stressors that led to this situation. The overall mental health situation is, and in terms of the level of the services and the accessibility of the services are not great, but also for youth in particular is even worse, because there is no discussion around the mental health for youth in the schools. There is no enough knowledge and skills among the school counselors to address any of the mental health problems for youth. The lack of the employment after they finish the school is another reason where it become another stressors for those people. All of those lead to worse mental health situation. Yes, go ahead, Jonathan.
Exactly. Well, I was informed that in certain levels of the society, particularly around the 20 to 25-year-old age group, there were up to 80-90% of levels of unemployment. That's true. The unemployment is one of the main concerns for the country, and we know that it's not getting any better in the last few years. Although the government keep promising the youth that they will find different better solutions, but unfortunately, the youth now they are in a kind of a situation that I have to say that they are hopeless, and maybe that would increase the level of the violence and also the domestic violence as well, and looking for different solutions as coping mechanisms that we are not in favor of. Yeah. Okay, perfect. So let's move on to our final question, or our pre-prepared questions, which is to what extent does stigma affect the behaviours of people with mental illness in your country? A very it's a difficult question to answer, but essentially to try and put some context at how people with mental illness are regarded and treated from a stigma point of view within the different countries that we've got represented. So, Murad, can we go back to you then for another 3.5 minutes?
Sure. I think it's important to dissect when we talk of mental illness. There's a spectrum at one end where people are distressed because of circumstances that may be temporary, but at the other end of the spectrum, you do have people suffering from psychotic illness where they have hallucinations, delusions, have lost contact with reality, and so on. So the stigma overall is there, and I think a lot of it is related to the conditions in the society, the literacy level, the education level. Pakistan, for example, is a country of 220 million plus people, but the literacy levels are less than 50%. And of the 50% that are literate also include people who can only read and write their names. So we're dealing with a mass majority of people, a large number of people who don't have access to written literature, for example. And when you don't have that, then all sorts of misconceptions and myths fill in that vacuum. And so mental illness is attributed to possession, for example, black magic, and so on. And so, what it does is it delays access to seeking help for mental illness. For example, one study that we did for depression, the time that the person gets the first depression symptom and then seeks help was about 4.5 years, the lag time of 4.5 years. And that included lack of awareness, lack of accessibility, lack of affordability, and also the lack of mental health services. So stigma is huge, partly misconception, partly ignorance, and that perpetuates the whole cycle of not seeking help from the right professionals. And because mental health services are very poorly developed, they end up being exploited with all sorts of people and services. And so that becomes a self-perpetuating problem. And by the time they do reach proper qualified mental health professional, the illness may be so ingrained that it may be really difficult to turn it back. And that's something that we do see in our clinical practice. But at the other end of the spectrum, very quickly, the distressed, the walking wounded are also hesitant to seek help for fear of being labeled as being weak, for example, as suffering from madness. And so it's really stigmatized. And I just want to add something. It is not only people and suffering from mental health problems who are stigmatized, even doctors like myself, psychiatrists, are stigmatized. So it's a very common, if you tell somebody, an aspiring psychiatrist or medical student who wants to go into psychiatry, if he shares it with somebody, one of the common reactions is, why psychiatry? What's wrong with you? So just an example of the pervasiveness of stigma and misconceptions that pervade the society in Pakistan today. Thanks.
Yes, perfect. Thank you. Yes, I know how you feel on that one, but we'll push on. Let's go to Helena. Your understanding of stigma and the way it affects people's behavior and mental illness in China.
Thank you so much. That's a great question. I concur. I echo Murray's concern about stigma in Pakistan. We have the similar situation in China. So not just the people with lived experiences, but also the psychiatrists, the doctors treating mental health illness could be stigmatized. I would add that in China, not individual, but also the individual's family members will be stigmatized too. So if someone have mental health illness, that means that it's not just their family's reputation will be damaged too. So that dates back to our culture, Confucianism, which emphasized the achievement of personal and social harmony. So people with mental health, disorders are often perceived as unable to fulfill this ideal. So their families will be stigmatized as well. The fear of so this kind of fear of being stigmatized and socially isolated will disincentive people seeking mental health care. And also, I found, as a mother myself, I found a stigma impacts on children and adolescents very seriously these days, because the children already face severe competition at school, high parental expectations. So compared with adults, young people here tend not to seek care for having public stigma as well as peer pressure. So a lack of awareness of mental health problem and stigmatized is harmful not only to the people with lived experience, to their family members, to the young people, and yeah, I know there are some concerning suicide news recently reported here. So I think that's a big problem, and we must address this issue in China. Thank you.
Fantastic. Okay, let's move on to Frank Anthony back in Guyana then. What is the extent that stigma affects the behavior of people with mental illness in your country?
I think like the two other presenters, both Pakistan and China, we do have a problem whereby stigma and discrimination often affect patient care seeking behavior because they don't feel comfortable coming to care. They're afraid of the labels, and not only for themselves, but the people who surround them. So it is a problem, and that is something that we have to fight against. one of the measures that we have taken is that with the new mental health law that we have passed, we have a section that is especially dedicated to the rights of patients. And one of those sections in that particular bill speaks to non-discrimination. So you cannot discriminate against a patient. So it's one thing to have it in the legislation, it's another thing to practice it. But we felt that it is very important to put it first in the legislation, and now we are going to build out programs around that to make sure that people, enjoy these rights. We feel that that is important. So our mental health strategy, the implementation and so forth that we are doing now includes this. And we felt that that was a very important step. Of course, one of the other things that we're doing, we want to deinstitutionalize patients. And so we have started that process. We have one main mental health institution, and we have a number of patients that have been there for decades. Our biggest challenge right now is that they've been there for so long, and while they can go back to their home, they don't have homes to go to because the family do not want to accept them back home. So that's a problem. So for the near future, we probably would have to maintain these patients, but the whole idea is to make sure that in their acute episodes, we're able to treat them, but then they go back home or they go to some facility in their community. So the idea is to treat them closer to their community. We have also started training a lot of our primary healthcare doctors so that these physicians can generally be able to look at psychiatric illnesses. This, I think, has been a weakness in our system, where a lot of GPs do not really look at mental illnesses. And a lot of persons who might have depression go undiagnosed. So we are hoping by doing things like this, we'll be able to detect people earlier. And once we detect them earlier, then we can put some treatment plan in place or put measures in place to assist these patients. And hopefully we'll see a decline in some of these illnesses.
I hate to, but what sort of level of psychiatrists do you have then in Guyana? Are you able to say?
So like Jordan, I think our percentages are quite low. But again, we probably have about 20 persons who practice psychiatry in Guyana. But we also have persons who they're GPs, but have maybe a leaning towards psychiatry. So not a lot of people. Recently, we have established a mental health unit. And again, we're trying to staff that unit with both psychiatrists and psychologists so that we can do counseling and so forth. So the emphasis now over the last 2 years or so have been much greater, a lot more interest. And therefore, we are building out this cadre that we need, both in terms of psychiatrists and in terms of psychologists. We have actually recently started a postgraduate program in Guyana where we'll be able to train our own psychiatrists. So this is a novel way of trying to get more people into the profession.
Yeah, fantastic. And again, Ahmad, you're the last to take the question. Are you able to give us an idea of the extent that stigma affects the behaviours of people with mental illness in Jordan?
Sure, Jonathan, thank you. Well, I think I have to agree with all my colleagues on what they mentioned, especially that the stigma is wide, and I have to say that it's widely expressed through the open utilization of terminology such as crazy, mad, and describe person with mental health disorders of high level of psychosocial distress. So, those are unhelpful labels, and consequent stigma are likely to lead to considerable shame and fear of embarrassment, and thus there are considerable barriers to seek help, and therefore prevent the patients or the people who are looking for the support to twist the effective mental health treatment. This stigma widens the therapeutic gap also, and disparity between the number of those or a need for psychiatric or mental health treatment and those who receive it, as well as also the weakness on the demands of the specialization by doctors and the nurses, as my colleagues mentioned, and lead to a severe shortage in the number of the service providers. Evidenced by, I visit my friends and colleagues who are even a private psychiatrists, that they are hiding their clinics and offices in places that people, whenever they go there, they feel like they have to be always go in secret and not to show their faces. Linking this with the suicide, I think the law on the criminalizing the suicide is also is increasing the stigma, and doesn't help at all of the efforts to try and raise awareness around the importance of seeking the services. In order to also to avoid seeking the service because of the stigma, there are a lot of coping mechanisms among the families where they try and go and seek services among people who are not professional, unprofessional, and also unspecialized, and they go for more of traditional healers, where they find it much more acceptable among the community, more than going to seek the service among the doctor or the psychiatrist or the psychologist. It ended up with less psychiatrists who are interested, and also less psychologists are interested because they are stigmatized. And on top of that, all of this, the people who are the community, they hide the illness just because they are afraid that the sister of that mental health patient will not get married, and also the entire family will be stigmatized. I know from a few cases, the 19 cases that since the law came out in 2022, and they were seeking they were referred to the court, their concern more were around the stigma around the mental health, more than even the legal consequences that they are going to face. That gives a lot of kind of understanding of the culture and also the all of these beliefs that they were developed in the last years, and contributed to this stigma.
Yeah. Yes. Are you able just to say, I'm allowed to, we talked about social media and what was happening in Jordan. Is there are you able to comment on that at all? Specifically related to suicidal activity outside?
I think there are the social media. They play kind of two rules. There are some that they contribute to the problem, and there are some they can contribute to the solution. And I can see that there are a lot of from when the law came out, there were a lot of Twitters and a lot of social media interactions with that, trying to help and support. But in the same time, we know that from social media, and whenever I notice that there is, for example, an interview for a mental health professional, I see over the comments and the people who are watching that there is this kind of negative attitude around the mental health and seeking mental health, as mental health is kind of something that luxurious that people they are looking for, and it's in general. Most of the people, they think that seeking mental health is an evidence that that person is weak and is not strong enough to face the mental health problems, and that's also very represented in the social media. On the positive side, there are a lot of platforms, a lot of applications that they came out, and they were trying to help and try to raise awareness around the mental health. But unfortunately, those are less spread among the community. And unfortunately, there are a lot of challenges around those, including the accuracy of the information, and also linking those people who are approaching those platforms or the applications to look for the service. Because part of it is try to address the stigma, but also the other part or the other challenges are linked with that, is including the accessibility of the service, availability of the service, and the quality of the service, where all of those are also kind of contributing to the overall mental health problem.
Yes. Okay. Fantastic. Well, there we are. I think we've reached the end of our panel discussion, and I now have the rather difficult task of sorting out these questions, and here we are. I will put some of them to our panelists, if that's okay, and we'll see how we get on. I'm a bit of a novice using this Q&A box, but we will let me grab a couple and see what comes of it. One here is, it says, is there any correlation between societal attitudes and suicide or attempted suicide and attitudes towards capital punishment? I'll read it again. Is there any correlation between societal attitudes to suicide and attempted suicide and attitudes to capital punishment? Is there anyone who would like to tackle that one? Yes, fantastic. Murad.
Well, generally, societies that are more acceptance of that have a more permissible attitudes towards suicide and attempted suicide, which is the opposite of being a punitive society, generally have higher suicide rates than those that have a much more restrictive or a non-permissive attitude. That's generally speaking. Of course, there are variations, and you'll always find exceptions. The other part regarding capital punishment, I don't know about that. But what I could certainly answer in an indirect way is, and I know it's not answering the question directly, is in many Muslim countries where the Sharia law operates regarding suicide and attempted suicide, a lot of suicides are misclassified as homicides. So it's not really capital punishment, but I just wanted to make the point that the death register where homicides are listed, so research has shown there is a correlation where in Muslim countries where homicide rates are low, suicide rates are shown to be, homicide rates are high, suicide rates are low, which means that the death registry of homicides are really a repository for undiagnosed or hidden suicides. Capital punishment, no, I can't really think of what the rates of what is the correlation between attitudes towards capital punishment and suicide rates. I know it's in the US, it's going up, suicide rates over the last few years, and numbers have actually gone up. And we know that capital punishment in the US is probably carried out more than any other country.
Yeah.
So we don't know.
Okay, good. Well, and another question here from a person called Ana de la Fuente is that being treated close to the community when stigma still is so strong, could it be counterproductive, is what I think she's asking. So is it better to treat patients with mental illness in the community, or should they perhaps be, as perhaps has happened historically across Europe and European countries, put away or shut away out of sight in asylums? Anyone want to have a look at that one? Yes, Yeah, Frank, I think that's right. Cool. We talked about deinstitutionalization prior, and then you mentioned it today. What are your views on? Let's talk about deinstitutionalization. Really, what is the local dictum on that?
Yeah, I think it's a transition that societies would have to make. Certainly, we are trying to do that here in Guyana, because before, basically, if somebody got some long-term illness, you lock them away and you lock the problem away so that the society doesn't see the problem. But the attitudes have changed, and we have to change the way that we treat patients. And as I've said, we have laid a legislative basis for that. Now we have to work and make sure these attitudes in our communities are changing. One way of doing that, we will have to work with the communities in education. And in fact, in our law, one of the things that we have been working on is to establish in health centers a sort of service to help to prevent mental health illnesses, things like suicide and so forth. And so we feel by introducing this into our health centers at the primary health care level, we'll see a difference in attitude. We have also, this is, in terms of stigma and discrimination, we kind of faced this when we were doing a lot of work in terms of HIV and AIDS. 20 years ago, there was a lot of problems relating to stigma and discrimination. And we have worked very hard to change people's attitude. I think we have been, by and large, successful at doing that. And I feel strongly that many of the lessons that we have learned from that campaign can be applied to mental health. And I'm sure that once we use those lessons, we'll be able to change attitudes in our community. Certainly, that's the basis on which we are working. And we feel confident that we'll change people's attitude in the community. So yes, I think it's important that as we deinstitutionalize patients, that we get them to come closer to where they live for those services.
Yes, I think that research will always show that patients treated within the primary care setting, which is where, I mean, at least 80% of patients, maybe more, are seen anyway, have much better outcomes than they do being treated at the secondary care level. Good. So there is a rather question directed really, Helena, it's rather controversial perhaps. It states that are mental health patients still being isolated and locked away due to their inability to integrate socially in China? What is? I know that it has rather a bad name. What is the situation? Would you say for the long-term mentally ill in China?
Thanks for the audience to bring up this question. And I think that's a long time ago. Nowadays, I admit that we have stigma, widespread stigma against the people with lived experiences, but the situation has changed substantially. I don't think we really log any mental health illness patients at home or in institution. On the other hand, what I'm happy to find out that the whole society has gradually understand mental health is as important as physical health. Like we just talk about community services to treat mental health patients. Actually, in China, not only community services, but also the schools have provided lots of mental health support to children and adolescents, recognizing the increasing depression and because of competitive school performances among the children. So as a mother, also I want to use as a mom, I have 2 kids at a kindergarten and at a middle school. What I'm really encouraged is to find out that the teachers, the schools, they have paid a lot of attention to this issue. They can open to talk about this mental health issue among students. So that's the good news. What I learned from China, and we don't log mental health patients at home. I think that's a long time ago. That's not what's happening in China right now. Thank you.
Okay, fantastic. Well, I'll just take one more, and it says here, does Jordan's or any other country's approach more broadly to criminal law also have any bearing on the decision to criminalize suicide? In that the questioner asks, I wonder how much crime and local history might also be a factor, relating back to my comment in the introduction, for example, on religion. Anyone feel they want to tackle that one?
I can try.
Have a go. Yes. Okay. Thank you.
Yeah. Well, I don't think there's a relationship or there is any correlation here. I think in general, there is what we need to consider, that this is a kind of a new trial from the government in order to reduce the level of the suicide, in their opinion, without looking into any professional or any specialized opinion. I think it's a matter of time when and a lot of advocacy work until the government decide and realize first that there is no relationship between, for example, any records or any crime records before and committing suicide. I think it's more of a matter of understanding of the problem rather than it's matter of linking the commit suicide with anything else, including the previous history for this person.
Well, that's right. The person I spoke to from the Ministry of Health said, accepted it was a mistake, accepted that the error, there was no relationship between the two. I think it comes very much from the military. That was my understanding, the military side of the government.
It's not Ministry of Health, agree with you, Jonathan. It's more of kind of it's a public security or kind of matter of more of looking into that from a security perspective more than Ministry of Health, and looking into from a treatment perspective. Yeah.
Yes. Okay. Well, look, I think we're rapidly approaching the end of time, and I think we can close there. I just want to know, what time is it in China? It's now approaching 1 o'clock in the morning. So I feel that we should allow Elena to go and go to bed, really. Although obviously everybody else is in a much more sort of sociable time. But I would just say, it just remains for me to thank everybody for providing with, I think, some very different perspectives on the law, and obviously it's still at such a changing situation, particularly with what's happening in Jordan. Thank you to our speakers, and also to those people behind the scenes whom you can't see but have been very, very important in organising this. And I hope that we've just managed to convey a little in our brief time here of the laws surrounding suicide and attempted suicide across the globe. It seems to me that influences on countries and current legislations, both ancient and modern, are still undergoing change, and there's still much change to occur. I just wanted to say that, interestingly enough, in the UK in 1961, there were 3 people that were rather incremental in bringing about decriminalising suicide. One of them was a chap called Rab Butler, and that was part of the Conservative government at the time, and a Labour MP called Kenneth Robinson, and a very eminent psychiatrist who also worked part-time as a magistrate called Doris Odlum. and it would shown that these three people, just three people alone acting almost together, were instrumental in decriminalising suicide in England and Wales, essentially showing that with sufficient motivation and perseverance, big changes can indeed be brought about by just a few people. My final line is that whatever the law, people in times of distress with mental illness should and need to be treated humanely and with kindness. And with that, I say goodbye and good night.
Thank you.